Okay, doctors, very good morning. So, I think we came to the ending part of the physiology. I think we have finished most of the physiology. I think we have CNS left. We will discuss the CNS today. We'll finish it off as fast as we can. And before completing it, I think one of the doctor has dropped me a question. Doctor, he just dropped a comment in my session like, sir, I know how an ECG looks in a hypokalemia, how a ECG looks in a something like hypertrophy, or even something like HOCM or cardiomyopathy or arrhythmias or atrial flutter, and he even know how what sort of changes might brought regarding this cardiomyopathy and everything. But that doctor asked me a question like, but sir, I just want to know what is meant by a vector. I was really surprised to hear such a statement from a doctor. How you can have, you know the patterns of every condition, but still you don't know something which is very crucial regarding a ECG, right? So the doctor knows everything, but he said he is very much confused about vector. It is like you marry a girl, but you don't know how to make her a mother. I mean, not mother. See, becoming a mother is something that depends on the character, not on the gender. But you don't know how to make her pregnant. That's it. You married a girl, a beautiful girl, is very good with a good character. Beautiful means regarding her character, she is very beautiful, but you don't know how to make her pregnant. So, what is the point of marrying a woman if you don't know how to do that, right? Even she will feel embarrassed to explain that, right? So, if you want to excel in ECG, you should know something about the vectors, right? If you don't know about the vector, it is waste of even looking at ECG, it is waste of time. Now let us clear the doubt of Dr. I think I would just wait, I'll say that name. I think it's Dr. Vanishri. The doctor's name is Vanishri. It is her. It's a female doctor. But Dr. Vanishri, please don't feel upset. Don't think like you're asking some basic, it may look like something very, no, don't think like that, right? See, even most of the experienced doctors, they forget the basics. So obviously they will go back to the books to explain it, to just get it all through that, right? So it is very much okay to learn the basics, even though if you are very much compelled to go into the depths of it, but if you don't know the basics, it's waste of time. So let us don't waste any other time. We will discuss what is meant by the vectors of ECG. So before knowing the vectors of ECG, we should know the basics of something called a galvanometer, right? It's a galvanometer, and obviously it has a needle. We'll just draw a needle here. This is negative, this is positive, and this galvanometer has two circuits which connect to two electrodes, right? So this is a muscle tissue. For example, we took let us say like it is a muscle fiber. It is a muscle fiber. See, all the doctors don't think like it looks like boring. No, don't think like it is boring. It is very much important for you. Don't think like it is only important for PG, but it's also important for your clinical practice also. If you don't know this, you cannot solve at least 80% accuracy regarding an ECG. You should know this, right? So you have one more circuit. You have one more circuit. Now it will be connected to the galvanometer as always. Regarding the electricity, you have a negative thing, you have a positive electrode, positive anode, and negative cathode, right? So what happens here is, for example, see, this is a muscle fiber. Say something like this is a muscle fiber. Wait, I will just drop it down with a red color. Let us think like this is a muscle fiber. Okay. Now, for example, this is point A, this is point B. Now I have stimulated point A with a stimulus, with an electronic stimulus, with an electrical stimulus, right? For example, I have stimulated point A. Now what happens is, it gets depolarized. So the depolarization goes on all along the cell. The depolarization moves all along the cell, all along the tissue. The depolarization moves on. So the depolarization, that potential wave is moving this direction. That is, the potential is moving from negative charge to, or the negative side to positive side. The potential charge is moving from negative side to positive side. So the potential is moving, the depolarization wave is moving this direction. See, I have drawn the direction also. So this direction, right? This direction, see, this direction. So it is moving from negative to positive. So obviously the galvanometer will show its pointer, will move its pointer towards the positive terminal, because the charge is moving from negative to positive. So the galvanometer will show the pointer towards the positive terminal. See this? Right. Now, so this is, so just obviously at one point of time the whole cell or the tissue will get depolarized. So there will be no charge that will be flowing from one point to another point. So there will be, because the complete tissue is depolarized. So the complete tissue is depolarized. So if the whole tissue is depolarized, or the group of cells is depolarized, there will be no any flow of charge. There will be no flow of charge. So obviously the galvanometer will come back to its original position, that is neutral position, like this. Wait, I'll draw one more thing. Wait. So what happens? The galvanometer will come back to its normal position, right? Is it okay? Okay, some doctors is having a confusion. I will just explain in a separate diagram. Wait. So this is a galvanometer. The needle stays in neutral position at the starting, right? Now, for example, when we exert, this is okay. Now, when we exert a stimulus, what will happen? Due to the movement of potential from negative side to, because we just initiated the stimulus on A point, on the A point. So the charge will be flowing from A to B, that is from negative to positive. So obviously there will be deflection towards the positive terminal of the galvanometer. There will be a deflection towards the positive terminal of the galvanometer. Now when the whole tissue or when the whole muscle cell has been depolarized, obviously there will be no charge or potential that will be flowing from one point to another point. So that's why when there is no flow of charge, will the galvanometer show any deflection? No. So the galvanometer will again come to normal position. The galvanometer will again come to normal state, that is neutral position. So the galvanometer came to neutral position. Now just think once again, after depolarization, what follows after depolarization? Repolarization. So depolarization is followed by repolarization. See, if some tissue or cell is depolarized, obviously it should come to its normal position, that is called a depolarization. It should come to its normal state, that phenomenon is called repolarization. And even one of the doctor has asked me a question like, sir, what is the difference between resting membrane potential and action potential? If someone asks us, see guys, it's very simple. It is in the word itself, resting membrane potential. So when the membrane is in a resting state, the potential or the charge present across that membrane is called a resting membrane potential. It's a simple concept. So the definition itself speaks the meaning. When the membrane, for example, it can be it's a muscle membrane, myocyte, or a visceral cell, or whatever, it's a neuronal cell or a cardiomyocyte. So whatever the cell is, when the membrane of a cell is in a resting condition, the potential or the charge that is being present on the membrane is called a resting membrane potential. That's why it is given with a name called resting membrane potential. For example, it can be -70, it can be -90, it can be -55, so it can be anything. So that is called a resting membrane potential. Now don't ask me why the resting membrane potential is always negative. I already explained why it is always negative, so don't ask me, right? So then what is meant by action potential? The action potential, so the name itself denotes it is action potential, something which is present during a movement. So it is the movement of the potential or the movement of the charge when a cell or a tissue is being depolarized, just because the charge is moving from one point to another point. So that's why there is some sort of an action, some sort of a movement. What is giving the movement? The potential. The charge is moving from one point to another point. So that's why that potential is given with a name called action potential. I think now you got the clear understanding what is meant by action potential and resting membrane potential, as simple as like that. Now coming back to the galvanometer, so we are discussing about galvanometer. So here, after a complete depolarization, the galvanometer again came to its normal state, that is neutral position. I'll write here, see, after complete depolarization. Now after depolarization, it is followed by which phase? After depolarization, it is followed by repolarization. It is followed by repolarization. During the repolarization, what happens? Repolarization, there will be what will happen in the repolarization phase? I already explained you. In repolarization, there will be efflux of potassium ions. There will be efflux of potassium ions. Why, doctors, why you are not speaking? Why you are not telling the answer? See, I already discussed it. When it comes to threshold, getting to the spike, there will be a small drop, calcium channels open, calcium influx occur, plateau phase, then obviously calcium channels close and potassium channels potassium efflux open. This is repolarization, this is depolarization, this is the plateau phase, right? As simple as like that. So this repolarization, during this repolarization phase, what happened? There will be a efflux of potassium ions. Due to rapid efflux of potassium ions, the membrane of the cell, that is cardiomyocyte, comes to its resting membrane potential. Again, it will comes to its neutral position, that is, it will come to its negative state only. So while coming to the negative state, that means the resting membrane, the membrane internal potential is getting converted into negative charge. During the repolarization, there will be re-establishment of negative charge in the membrane of the cardiomyocyte. So the negative charge polarization will be moving from point B to point A. Now observe carefully, here the negative charge is moving from point B to point A, that is from positive terminal to negative terminal. Now tell me, towards which direction the galvanometer will deflect. Now this answer of yours will tell me that whether you have understood or not. Now here the negative charge is flowing from positive terminal to negative terminal, positive terminal to negative terminal, point B to point A. Now tell me, towards which direction the galvanometer needle will deflect. Tell me. So this is negative, this is positive. Tell me, towards which direction the galvanometer will deflect? Yes, it will deflect to, no, why it will deflect to negative? So negative going to negative, always the galvanometer will deflect towards positive. It's not negative, positive charge only. When there is a negative charge flowing from positive to negative, then obviously the deflection of the galvanometer will be pointing towards positive only. It's not negative. So you might get a doubt like, sir, then if the positive charge is going from negative to positive, then also it will show to positive, and a negative charge going from positive to negative, then also it is showing positive. Then when will the galvanometer deflect towards the negative? Yes, it's very common thing to you to get such a doubt. So I will tell you the answer. So when the galvanometer will show the negative deflection means, I will tell you here. For example, this is a galvanometer. This is a galvanometer. This is positive, this is negative terminal, this is the positive side and this is negative side, and this is the needle itself. Now for example, let us say like we have muscle cell here or tissue here, see, muscle cell or tissue here. Now this is point A, this is point B, this is the positive side, this is the negative side. Now for example, if the initiation of stimulus is done on the B side or on the B point, for example, if the stimulus is applied here at this point, it means at the B point, That means the stimulus is applied towards the positive region, towards the positive side region. So the positive charge will be flowing. That is the depolarization wave. That is called just simply remember, that is depolarization wave. Remember, depolarization wave. So the depolarization wave is moving from B to A. That means from positive to negative. Now tell me, towards which direction the galvanometer needle will deflect? Anyone? So the galvanometer, now it will deflect towards the negative side. Now you understand the basics of ECG. If you understand this, you have understood the basics of ECG. Now the galvanometer will deflect towards the negative side. Why? Because the positive charge is flowing from positive to negative. So obviously the galvanometer will deflect towards the negative side. Okay? Now, so this deflection or the flow of charge, the flow of depolarization wave or the repolarization wave, will be represented by a component called vector. Will be represented by a component called vector. So just we will speak something a little about vector, just only one or two sentences. A vector has two components. One is direction and another one is very important, that is the magnitude. Don't think like we are entering into physics. No, we are in the medicine only. Just remember this statement. It is just basic physics, very basic physics. We don't calculate V1 hash plus V2 hash plus V3 A cos theta B sin theta. We don't calculate all those things, and we don't even need all of that, right? So the only thing I want you to remember here is the vector has generally two components. It's a basic natural rule. It's just a rule. Don't think like it is a formula. It is just a rule. It has both direction and a magnitude. Now if we bring this vector concept here you have the flow, or you have the direction on which the charge is moving. Either it's a depolar, if for example the stimulus is applied towards the A side, A is negative, B is positive. So if the stimulus is initiated on the A point, so the direction of the depolarization wave is going from A to B. A to B. The direction of the flow of charge, the direction of the flow of charge or potential or depolarized wave is going from A to B. So the direction of the vector will be like this. This is the direction of vector. So regarding the rule of vector, what did we explain? What did we just explained about vector rule? The vector has two components. What is that? It has direction and it has one more thing. What is that? Magnitude. So we discussed about direction, but what about magnitude? Magnitude is, see, I will explain. For example, previously we took only a muscle cell or a muscle tissue. Now for example, let us say like this heart is not good. I will draw one more heart. Okay, now let us say like these are atrias and these are ventricles, right? For example, I will just take this piece of ventricle, right? Now I will just take this piece of ventricle. Wait, I will draw neatly. I will just take this piece of ventricle and I will just connect two electrodes to this ventricle. See, this is a piece of ventricle myocardial tissue. This is a piece of ventricle myocardial tissue. Ventricle myocardial tissue, right? So if we connect 2 points to a galvanometer, for example, here we just took a muscle cell. Just please be on the line. So here we took a muscle cell on which we connected galvanometer. So the charge flowing in a muscle cell, when we compare a charge flowing in a muscle cell and a charge flowing in a muscle tissue. This is ventricular myocardial tissue. See, this is ventricular myocardial tissue. And so, is there any difference when a charge flowing in a muscle cell and a charge flowing in a muscle tissue? Is there any difference? Yes, there will be a difference. There will be a difference in the magnitude, how much charge. So the quantity of the charge flowing in a muscle cell is less than the quantity of charge flowing in a muscle tissue. See, I will just explain to you. Now for example, this is a muscle cell, say something like muscle cell. But if you want to show a muscle tissue, a tissue is a group of cells, right? A tissue is a group of cells. So this is a muscle tissue, this is a muscle tissue. See, this is a muscle tissue. Now if we connect galvanometer to muscle cell, and if we connect a galvanometer to muscle tissue, now if we just try to depolarize it, and if we try to observe the deflections in galvanometer, which one will have more magnitude or more quantity of charge is flowing in which condition, either in muscle cell or muscle tissue? In muscle tissue you will have more charge flowing. There will be a flowing of more amount or more quantity of charge. So that more, the so-called more which you are yelling or spelling here, the more or the quantity that you are representing here is the magnitude of the charge. Now can you represent magnitude on the vector? If we can represent a direction, then obviously we can represent the magnitude. But how you can represent the magnitude? The length of this vector, will define the magnitude of the vector, or magnitude of the component, whether it is charge or velocity or direction, whatever it is. So it will represent the magnitude of the vector. The length of this vector will show or will tell us the magnitude of the vector. Now this direction, the direction to which this pointer is pointing out. Now this pointer is pointing out, that direction explains you about the direction of flow of charge, or direction of the vector. This length of this so-called vector explains you about the magnitude of charge, right? So for example, if a charge is moving in a cell, so less amount of charge will be moving when compared to a charge moving in a tissue. A charge moving in a tissue will have a high magnitude, more quantity, and it will have a long vector. Now you understand, right? So a vector have two components. Always remember, vector will have direction as well as the magnitude. Now bring all this concept to a heart, to our favorite heart. Bring all this concept to a heart. Bring all this concept to the heart. We'll discuss something regarding this heart here. Okay. So right now, this is our left ventricle. This is our left ventricle. This is our right ventricle. Right? Don't think like my drawing is not good, but just listen to the concept. Just listen to the concept. Don't think about the drawing. Leave over the drawing. But I'll try to explain everything I can. Okay. Now these are atrias. And these are ventricles. Remember, these are ventricles. Now, for example, now actually here you will be having SA node, right? Here you will be having SA node, okay, and here you will having AV node, right? SA node and AV node. Now we should draw some other structures, very important. So you will have AV node, and wait, you will have AV node here, it's not here, and you will have AV bundle. This is AV bundle from AV bundle we will be having left branch bundle, very important, left branch bundle that will supply to the rest of the ventricles, and you will have one more branch, that is right branch bundle, that will supply to the walls of right ventricle. As simple as like that. Okay, so now we will discuss the charge. So now who fires the initial charge or the potential? It is the SA node. Being SA node as the pacemaker of heart, it fires the potential that is needed for the initiation of the heartbeat. So here you will get a potential, here you will get the initiation of charge. The potential flows all around the atrias, all around the walls of atrias, all around the walls of atrias, right? The potential simply flows all around the walls of atrias. Finally it will be coming to the AV node. AV node, you will be getting the AV bundle. Now this is actually a, remember, this is actually a fibrous septum, fibrous septum, or you can also, it's actually, it's the physiological nature. This fibrous is determining its morphological aspects, but actually it is defined as atrioventricular septum. It's actually named as atrioventricular septum, which is actually fibrous in nature. So this fibrous name is determining the nature of the component. So why I am telling about this fibrous septum is because this action potential which is generated and it is spreading all across the atria's walls, this potential cannot cross the fibrous septum. Remember, this potential cannot cross the fibrous septum, means the conduction of the impulse, the conduction of the heartbeat impulse, it cannot transfer or it cannot travel through the fibrous septum. So how it will be conducted to the ventricles? So the only pathway is AV bundle. Remember this statement, it's very, very important. Only AV bundle helps in the conduction of impulse, electric impulse that is needed for the heartbeat from atrias to ventricles, atrias to ventricles. Fibrous septum will not accept the conduction of heart. It will not conduct the electric impulse. Please remember this concept, very, very important. Now the so-called flowing from the electric impulse conduction from SA node to AV node, it goes very fast, very quick. Now we will represent ECG here. Okay? Now we will represent ECG here. I will draw a straight line which is actually the base value or the zero, which it defines it as a 0. Okay, now this is a 0. Just wait. Now this is 0 value. So above 0 it is positive and below 0 it is negative charge, right? Now as the conduction is going on, so actually, so when the atrias all undergo depolarization, the depolarization wave is going from SA node to all along the atria walls, the walls of atrial chambers, and from there we already discussed it cannot travel through fibrous septum, so the only gateway is the AV node through AV bundle. So when the so-called depolarization goes or travel through the atrial walls or the atria chamber, you get a P wave. So this is the P wave. So the P wave is seen in atrial depolarization. Atrial depolarization. Now most of the doctors, even some of the experienced doctors, don't know why the P wave is on the above the baseline. Why it is not below the baseline like Q wave or S wave? Why P wave is not below the baseline? Because at this point now you should apply the concept of vectors. Now you will get it why P wave is above the baseline. Now if you observe here, the depolarization is moving from, wait, I will just scroll it down. Actually we should write something here. So while we connect the ECG, we will connect the right, we will connect the right hand or right arm with one lead, and if we connect the left leg with another lead, say something like positive, this is left leg, right? See, you can place it anywhere, but these are normal placements, right? Now when we connect the ECG, we'll generally place the placement like this. So negative side on the negative terminal on the right hand, and the positive terminal towards the left leg. Now if you observe here, the potential charge or the action potential is moving from SA node to AV node or towards the AV bundle. So let's just describe it like AV node. So from SA node to AV node, so the charge is moving like this, in this direction. The charge is moving in this direction. You see this? The charge is moving in this direction. So this is the direction of the movement of action potential. That is, that the action potential is moving from negative terminal to positive terminal. The action potential is moving from negative terminal to positive terminal. So it is going from negative to positive. The charge flow is going from negative to positive. Now will the ECG have a positive deflection or negative deflection? We already discussed, when the charge or the depolarization wave, when the positive charge or depolarization wave, when it is moving from negative to positive, the galvanometer will have positive deflection. So that is the reason the P wave is actually above the baseline. It is above the baseline. Now you understand why the P wave in a ECG is above the baseline. That is the reason. Now after completion of the P wave, that means after completion of the depolarization of the atrias, the action potential will move towards the AV bundle. Why? Because the fibrous septum will not conduct the action potential. So the only gateway is through AV bundle. Now the AV bundle is a different type of tissue. Why I just note it down as different type of tissue? Because it is very slow conducting tissue, very slow conducting tissue. So during the conduction of impulse through the AV bundle, there will be a delay of 0.1 millisecond. There will be a delay of 0.1 second, sorry, 0.1 second. There will be a delay of 0.1 millisecond, right? Now, why this delay? Why nature has kept this delay? Can anyone tell? I will only tell the answer. The nature has kept the delay because in order to make the heart to pump in a correct manner. If the delay is not there, what happens is, by the time atrias complete the systole, the ventricles will also start the systole, and there will be a imbalance. So there should be a time gap by which after the completion of atrial systoles, then the charge will be moving towards the ventricles. Then the ventricle starts to depolarize. By the time the AV valves close, the semilunar valves open, and by the time ventricles contract, obviously the blood flow will be directed towards from ventricles to semilunar valves towards the aorta and the pulmonary trunk. So that is what happened. That is the main concept. The nature itself has designed in such a way that the AV bundle has a delay. And don't think like it doesn't have any physiological reason. Yes, the AV bundle tissue is something like the cells are arranged side by side in a layers like, right? So actually the charge is moving like this in a perpendicular direction, So it should move all across the cells like this, and the cells are also very small and it's very thick. So all the cells must depolarize in order to conduct that wave all along these layers towards this side, towards the ventricles. So that is the reason there will be a delay in the AV node. That is the main reason. So the AV bundle delay. So the AV bundle has a delay. So after the AV bundle has, no, we should represent something on the ECG now. So when the AV bundle has a delay, then what will happen on ECG? You will get a straight line. You don't have any deflection, you will have a straight line. Why? Because why there is no deflection? Because AV bundle delay is there. There is no flow of charge. It is just a delay. The so-called, there is no flow of charge actively. So you will get a straight line on the ECG. Now this straight line on the ECG before the QRS complex, we call it as P. We call it as, anyone? We call it as PR segment. That is called PR segment. PR segment. PR segment is different from PR interval. Please don't confuse. PR segment is different from PR interval. For example, this is P wave and this is the it is the interval where there will be no flow of charge. It is actually conducting through the AV bundle. So this line which is present on the ECG represents the conduction of impulse through the AV bundle. So here you will start the Q wave. So this is Q. So this from here to, I will just draw it black. From here to here it is PQ segment. But if someone asks the interval, from here to here, it is PQ or PR interval. Okay, you got it? I am explaining so many things. Don't confuse. You just listen, right? No need to get confused, right? So that is the difference between PR segment and PR interval. We will discuss that later, right? Now, so we finished. We came to where? We came to AV bundle, and the AV bundle does not have any active conduction, so it will be shown as a blank line on the base of the ECG. Now after AV bundle, we will be flowing the conduction. The conduction of the impulse will be flowing towards the bundle branches. But which bundle will transfer the impulse, electric impulse or action potential first? Always remember, left bundle branch will transfer the electric impulse first. It's not the right bundle branch. The left bundle branch will receive the impulse first and it will conduct the impulse first. The left bundle branch. Okay, the left bundle branch. Now this left bundle branch, when it receives the impulse, it straight away takes the impulse, electric impulse, and the depolarization wave flows like this. Now the question is, which part of the ventricle chamber will receive the depolarization wave first? Is it the walls? Is it the base? Is it the apex? No, it is a big no. The first part in the ventricular chambers to receive the depolarization wave is ventricular septum. It is not the walls, it is the ventricular septum. Now if you ask me which point of region in the septum to receive the impulse, if you ask me like this, I can even show you the point, that is this part, the left wall of the ventricular septum. This part is the first initial part to receive the depolarization through the left bundle branch. Now this portion, this left side portion towards the apex region, this portion is the first component to receive the electric impulse, or something called the action potential or the depolarization wave. So the depolarization from this segment of ventricular septum, it flows towards the rest of the ventricles like this. So rest of the septum will get its depolarization wave like this. The rest of the ventricular septum will receive the action potential like this. Now if you observe here, the so-called depolarization wave is moving towards this direction. You see this blue arrow? This blue arrow, it is moving towards this direction. So the depolarization is moving like this, in this direction. That is from positive to negative. So when the charge or the electric potential or the action potential, when it moves from positive to negative, the galvanometer deflection will show towards the positive or negative. which direction it will show the deflection? When the electric charge or the action potential is moving from positive to negative, will the galvanometer will deflect towards negative or positive? It will deflect towards the negative. So that is why the Q wave is present, or it will come below the baseline. See in the ECG here, the Q wave will come below the baseline. It is on the negative side. The Q wave is on the negative side. Now after the ventricular septum, the next components to receive the action potential is the inner walls of the ventricles. What is that? The inner walls of the ventricular chamber. The inner walls of the ventricular chamber. This inner walls of the ventricles will receive the what is that? Will receive the action potential. This inner walls of the ventricles. From this inner walls of the ventricles, or from this myocardial segment, the action potential will move, or the depolarization wave will move like this towards the outer walls of the ventricles or towards the pericardium, right? It will move towards the pericardium, right? Now see, the depolarization is moving like this. Now actually there are so many vectors, but if you take the mean vector, means average of it, if you take the average of it, the vector will be pointing like this. A big vector, a big average, or something called mean vector. This is called mean vector. See, the direction is pointing towards the positive region. So the depolarization wave is moving from negative to positive region, negative to positive region. So if a charge is moving from negative to positive, how will you represent? How will the galvanometer deflection be? Will the deflection be towards the negative or positive? If the electric potential or action potential is moving from negative charge to positive charge, will the galvanometer deflect towards the positive or negative? It will deflect towards the positive, because the action potential is moving from negative to positive side, so it will deflect towards the positive. Now we will get a question in ECG, why the R wave is so taller with respect to P wave or S wave or Q wave or T wave. Why the R wave is so much taller? Now if you have the concept strongly, you can tell the answer very easily, very easily. It's very simple to tell the answer why the R wave is tall, as well as it is lean, it is thin. Do you think the R wave is thick? No, the R wave is tall and it is thin, tall and thin. That means it has a very short interval of time, as well as a tall wave. Now why the R wave is taller and it is having a very short interval of time? Why? Any answer? Why the R wave is taller and short, and it has very short interval of time? See, very short interval. Why? The answer is simple, guys. The walls of ventricles. Do you think the walls of ventricles are thin? No, the walls of ventricles are the extreme thick tissue in the complete heart anatomy. The walls of the ventricles are the thick portions, most thick portions. Why? Because they are the active pumping chambers. Obviously the walls of ventricles are extreme thick. Now how do you think they can get hypertrophy in such a magnitude? How? Because their walls are extreme thick. They have a lots of myocardial tissue that gives this thick component for the ventricles. Now when there is a thick muscle, there is a lot of tissue. When there is a lot of tissue, obviously a lot of charge will be flowing easily. More action potential charge will be flowing. If there is a flowing of more amount of charge, the magnitude is also more. If there is of more magnitude, obviously there will be a rapid deflection and there will be more magnitude, and obviously it will come to its normal state. So that is why the R wave is taller in a ECG, while the P wave and T wave and rest of the waves are shorter. The R wave is tall and it is very less interval oriented thing. Now why less interval? Why not it's having that much time interval like P wave or T wave? Because here the conduction is done by some fibers called Purkinje fibers. Why Purkinje fibers are the most fastest fibers regarding the heart neural tissue? The speeds and velocity are something like 4 meters per second. Why that 4 meters per second when compared with other neural tissue in the heart? Why Purkinje fibers are that much fast? We will discuss later. Okay, now only I will tell you the answer. See, the Purkinje, previously I told you about the AV nodal fibers. The AV bundle, the cells are placed like this, very short cells, small cells in stacks, multiple stacks. So obviously you need more time to travel all along that stacks. But when it comes to Purkinje fibers, the Purkinje fibers have special cells which are long and they are very lenient in number. So obviously the charge moves actually like this, just like this. So it needs very shorter amount of time, very small number of cells will be there in Purkinje. So that gives the amazing maximum velocities in Purkinje fibers. Maximum velocity in Purkinje fibers. How much is that velocity? It is something like the electrical conduction velocity in Purkinje fibers is 4 meters per second. So we discussed why the R wave is tall. So obviously the vector, the magnitude of vector in the direction of depolarization from the internal myocardial layer of the ventricles towards the external walls of the ventricles, which are last to get depolarized. So that is why due to the thick ventricular tissue we get a tall R wave, and due to the rapid conduction of the Purkinje fibers we get a short interval in the R wave which is very rapid, right? Now after that what happens? So here I will just show you here at this point you see this. Now these are the basal portions of ventricle. These are the basal ventricular portions. These basal ventricular portions, here also the depolarization moves towards the basal portions of ventricle. These basal portions, right? Now while the charge is depolarization wave is moving towards these basal portions, so obviously the depolarization wave will be moving like this. So the charge is moving from positive to negative. The charge is moving from positive to negative, right? If the charge is moving from positive to negative, you will get a positive deflection or negative deflection. You will get a negative deflection. That is why the S wave is again below the baseline, that is towards the negative region, towards the negative potential. That is why the S wave is towards the negative potential. After that what you will have? So it came to the base. Obviously there the so-called, what happens? The complete ventricular tissue, now it is depolarized. Now the whole of the ventricular tissue is depolarized. Now if the depolarization of the tissue has occurred completely, will there be any transfer of charge that is being takes place? No, there will be no transfer of charge or no transfer of potential. Now that is what we see here, this straight line on the, wait, I will draw neatly. That is what we see here on this ECG. That is a straight line from S wave to where? S wave to next component. Now after the ventricle gets depolarized, obviously what is the next thing to get repolarized? Obviously what is the next thing? Repolarization. The next phase after depolarization is repolarization. Now there is a rule in the ECG that the first thing to get depolarized is the last thing to get repolarized. The first thing to get depolarized is the last thing to get repolarized. Now according to this statement, now can we say that the last thing to get depolarized will be the first thing to get repolarized? Can we say like that? Now according to this statement, the first thing to get depolarized is the last thing to get repolarized. Now if you reverse the statement, the first thing to get the last thing to get depolarized, will it be the first thing to get repolarized? Okay, I think some doctors confused. I will write down here. Don't get confused, man. See, it's not confusion. I'll write here. The first part of heart to depolarize will be the last part to repolarize. Now you can understand, right? I will written down the statement. So the first part in the heart to depolarize will be the last part to repolarize. Now can we say that the last part to depolarize will be the first part to repolarize? Can we say like that? Yes, we can say like that. It will be the first part to repolarize. Right or wrong? It's obviously right. Now what will happen here? Repolarization means again the charge will be coming to the normal state. The charge will be coming to the normal state. Now if we talk about the repolarization, obviously the last part to get repolarized is the which one? Basal part or the apex part? Anyone? Basal part or the apex part? It will be the basal part. So when the basal part gets repolarized, so again the repolarization occurs, right? So as the repolarization occurs, you will get a T wave. That's it. So this is the ventricular repolarization. So slowly the repolarization occurs, right? So we will draw here neatly. Okay, we'll draw here neatly. Take a graph and we take the red color. So there will be a P wave. So the P wave is conduction of action potential from SA node to AV node towards the AV bundle. The AV bundle will take a delay, right? The AV bundle will show some delay in regarding the transfer or conduction of electric potential. We will get a delay near the AV bundle. So after the AV bundle, there will be transfer of conduction potential towards the left bundle branch. The left bundle branch will first depolarize the left part of the left wall of the interventricular septum. The interventricular septum, from interventricular septum it will depolarize all along the interventricular septum towards the negative side, right, towards the negative direction. So there will be observing of Q wave. After the interventricular septum, it will spread all along the walls of ventricles, and the direction of the flow of charge will be from walls of the ventricles to from the inner walls or the myocardium of the ventricles towards the pericardium. So you will get a tall spike R wave. So you will be having flow of charge from negative terminal towards the positive terminal. So there will be a long R wave. So after this R wave, it will comes to its normal state, and again you will have direction of flow of charge towards the basal part of the ventricle. So you will get an S wave. So after that S wave, you will be getting towards the normal state. Then obviously the ventricles will get repolarized. After the ventricular repolarization, After the ventricular repolarization, then again it will come to a normal state. And some of the students are asking me, sir, there is also U wave. We heard about a wave called U wave, which is small wave, U wave. See guys, this U wave is nothing but, see, I will explain here. U wave is nothing but, now this is heart, this is heart. Now U wave is nothing but, here you have something called, what is that, valves, right? These valves, this mitral valve on the left side, mitral valve or bicuspid valve on the left side, and the tricuspid valve on the right side. So these valves are connected with papillary muscles, and these papillary muscles are connected to the valves, the atrioventricular valves, that is the mitral valve and the bicuspid valve, with the mitral valve or bicuspid valve and the tricuspid valve with the help of chorda tendineae. Now what happens is, sometimes these papillary muscles, they show a separate depolarization content. So they sometimes depolarize, they depolarize separately. That depolarization shows us on the ECG with a small U wave, okay, with a small U wave. So that is the reason behind this U wave, but most of the times you don't see this U wave. Sometimes you may observe, but if someone asks you what is this U wave is, this U wave is due to depolarization of this papillary muscles, right? This is P wave. Understand everyone? I think everyone got an idea regarding this. No doubts, right? Everything you understood, okay? I think it is sufficient up to here. So this is the basics about vectors, right? This is the basics about vectors and how you got the ECG and what are these components. So with this, okay. Sorry. So I just forgot to tell you. So first we will talk about waves: P wave, Q wave, R wave, S wave, T wave, U wave. So just leave about this Q wave. We don't want right now. P wave due to atrial depolarization, QRS wave due to ventricular depolarization, T wave due to ventricular repolarization. Now someone is asking, sir, why we cannot see atrial repolarization on the ECG? See, atrias are actually small chambers, first one. Second thing is, they have thin walls, that means less amount of muscle tissue is there to show the deflection. But the most strong reason for it is, by the time the atrias repolarize, the ventricles will be in a state of strong depolarization. So obviously this strong depolarization dominates the repolarization changes in the atrias. The strong depolarization in the ventricles, obviously it masks the atrial repolarizations. That is why the atrial repolarization cannot be seen on a ECG. Okay, answer. So PQRS T wave. Okay, now if we discuss about segments, the first segment is PR. You can call it PQ or PRC. Okay. Why sometimes doctors call it PQ, sometimes doctor call it PRC? It's very simple. Not all the ECGs will show you the Q wave. Sometimes or most of the times you may not observe Q wave. Most of the times, but sometimes or rest of the times you can see the Q wave. So that's why sometimes doctor called PQ segment, sometimes doctor called PR segment. So this is PR segment. But if someone asks you what is PR interval, so if you take from here all along the way to here, now this is called PR interval. This is PR interval. This is PQ say PR segment. This is PR interval. Now if we come to ST segment, this is S, this is T. This is ST segment. This is ST segment. Now if you ask me ST interval, you take it from here to here. This is ST interval. Okay, this is ST interval. Okay, now some of the doctors are again asking me, questioning me, sir, why U wave? See, that is what I am saying. U wave is nothing but U wave represents the depolarization that we observe in the papillary muscles. But don't get fear. Right? See, U wave maximum it doesn't appear on the ECG. Trust me. Maximum times U wave doesn't appear on the ECG. Maximum times U wave doesn't appear on the ECG. Okay, so don't bother about it. Now someone is asking, sir, there is one more interval. Which interval you are? Yes, I know what interval you are talking about. Don't get panic. I know what you are thinking. The Q and T. This is what you are thinking, right? This is the QT interval. Happy? All happy? Okay. Now with this basics, again I just want to repeat the thing very simple. Okay, please don't think like Sir is telling us again and again. No, it is for your good only, so that you can at least understand the ECG, at least you can try to know what you are dealing with. Okay, so P wave due to atrial depolarization, you get a P wave. This PR segment is due to AV bundle conduction. AV bundle conduction is shown as PR segment, and the Q wave occurs due to conduction in the interventricular septum, right? That is Q wave, and the Q wave follows the flow of the action potential all along the walls of ventricles towards the pericardial side, that is from inner walls of the ventricle to the pericardial surface. Now after that there will be this is R wave, right? Now after that there will be a flow of action potential from walls of the ventricles towards the basal part of the ventricles, so that gives S wave. From there again you will be having a delay. Why you will have a delay? Is this a delay? No. Is this a delay? No, as well as yes, because the ventricles have been completely depolarized. So before initiating the repolarization, it will be taking some time. So the repolarization of the ventricle is shown as a T wave. The repolarization is shown as the T wave. Okay, understood. Now for example, if there is a problem in the AV conduction, so here you can see the problem. If there is a problem in the atrial contraction, so here you can see the problem. But if you see the problem in T, for example T wave, so you can simply say that there is a problem regarding the ventricular repolarization, or there is a problem lies with the ventricular surface. Or if you say that if there is a problem in this wave, that is the ST segment, then obviously you can say like there is a problem regarding the flow of conduction. If there is a problem in the R, R wave, so you can easily say that the walls of the ventricles have some issue. So now you understand each and every segment of ECG. Now you got to know how you can analyze ECG preliminarily. See, I am saying preliminarily, not like an expert or a pro, but as a preliminary investigation you can get. Happy? Okay. So the next session we will start with physiology. We will finish physiology and we will start surgery today. Okay, we will start surgery today. Okay, thank you. We'll start with the next session. We'll take a small break. Thank you. Show wise doctor.